So this was the name of the lecture that I was kind of assigned, the structural basis of life. But I felt a little bad about using that because that's the name of this small text that was written by Graham Scarr, who's a DO from Scotland. And I met Graham at the Biotensegrity interest group that Steve Levin runs. And that group is mostly DOs from Europe, where they don't do injections, right? They're really more manual treating physicians in Europe, not like here, where DOs are becoming more and more like MDs, doing the same residencies and doing all the same procedures and surgeries and everything. So I decided I didn't want to steal his book title, so let's call this Biotensegrity, the Anatomy and Biomechanics of Nature. And I have no relevant financial disclosures. This is an article that I hope some of y'all will read in detail. And it's I just put this out in P&R Clinics of North America. And there's many videos associated with this article. If you have a subscription to P&R Clinics, if you don't, talk to me. Maybe I can work with you to get the videos. So because it really, to understand these concepts, you have to go through in detail with individual cases, I think. You know, we like to use large data sets to validate what we do as treatment, but to understand things tensegrally, you really have to treat a person as if they're a whole person, and that you're seeing the entire system as one. And so in this article, I tried to make the key points that prolotherapy by tradition has been injection ad enthesis. So the idea that George Hackett came up with is we need to strengthen the weld to bone of these connective tissues. So tendons where they insert, your tender pushing on that point, or it feels like there's a little crepitus and there's a little tenderness, then you pepper that and inject and stimulate a repair process. But what's been missing from this is a diagnosis of pathology at all these enthesis points. There's some, Achilles tendinopathy at the insertion. That's been shown and proven. But what about the posterior layer of the thoracolumbar fascia at the posterior spinous processes? What pathology is there? Well, we haven't proven there is any pathology. We just feel there and it feels tender, so we inject some dextrose or something else and people get better, and we can't really explain why. So this article is an attempt to say, hey, we can see the pathology now because we have a high-resolution dynamic ultrasound. We can see what's going on at these points that are tender to palpation, and then we can treat those. And I make the argument that prolotherapy cannot be understood unless you understand biotensegrity. So you can always just dismiss it as these sugar injections, or as years ago, an orthopedic surgeon that I went and heard a talk, and he mentioned prolotherapy. And he said, that's those saltwater injections. I don't put any credence in that. And he moved on to the next thing. And I was just like, please understand the basics of what you're judging before you judge it, please. And that applies to all of us, right? So Biotensegrity provides a fundamentally different understanding of biomechanics and thus diagnosis and treatment. And so the best way to try to understand these things is a very detailed case study. If you have access, oh yeah, I keep clearing my throat, thank you. If you have access to the lectures from last year, I went through one detailed study in about a 45-minute lecture, so it might be worth going back and reviewing that. So our goals for this part of the lecture are to understand the unique characteristics of tensegrity structures in general, reframe our anatomy and biomechanics, and then try to apply that biotensegrity knowledge to just couple of traditional muscle tests. So one of my favorite quotes, what he saw as one was one, and what he saw as not one was also one. And then he saw the unity, he was of God, and then he saw the distinctions, he was of man. Science is all about being of man, right? We all look for the distinctions. We break things down and reduce things to the smallest denominator, try to understand one thing, and then of course we lose the forest for the trees. And then we don't see the whole. So as physicians, as orthopedic, integrative medicine, functional medicine physicians, we need to oscillate back and forth between these things as much as we can. We can't be God, obviously, but we can approach more of a holistic viewpoint if we pull back intermittently and see the whole patient, and then go in and focus at the details and then pull back, and always be willing to oscillate. back and forth between those things. So how do we understand the dyscerebrate cat? Y'all ever seen this video? Some of y'all last year saw this video. I showed it. Have you ever seen this model before? This is on YouTube, right? So this is a dyscerebrate cat. He's kind of supported a little bit with some strings there. And as the treadmill starts to go, he starts to walk. Then he starts to trot, and he starts to run. And none of this is managed through his cerebrum, right? It's all below that level. So if we move him out of the way, this has been studied. It's been a classic model, actually, of trying to understand the neurologic system and what is it that controls ambulation. So control of locomotion in the dyscerebrate cat. It is showing up. So only in recent years have we looked at the mechanism and analyzed in detail of how this happens. So it starts in the mesencephalic locomotor region and goes through all these other structures that we learned in neuroanatomy in medical school, and I probably forgot, then tried to relearn in the neuroanatomy course that I had in PM&R residency, and then forgot a lot of it. And it's difficult because I can't see it. I'm a very visual learner, obviously. So here's our dyscerebrate cat again, and just watching him, unconsciously what we are doing when we see movement is we're seeing this. We're seeing the bones, and the bones are the frame. And so what we're thinking is, how does that bone get pulled in that direction, and how does that joint move? Well, we start learning muscles based on that. And actually, before we ever have any medical education, we learn this model, that this is the frame, this is the base frame of who we are as biologic creatures, is these bones. And we learn it when we're very young, especially like in a Hispanic culture. You're going to learn Dia de los Muertos, and you're going to see that cat. The inner workings of the cat are really the skeleton, and that's the structure. And of course, we do that with Halloween. We have skeletons everywhere when we're little kids, and we unconsciously know that is our structure. And then, so when we see someone walk, we think they're pulling on their bones and they're moving that leg forward. They're moving the femur forward. They're moving the tibia backwards, swinging through. And it's the muscles that are attached to those bones that are doing that movement. And of course, that is not how we move. And that is not the structure. So here's a case that I showed last year in detail. This is a guy who has sciatic nerve pain. He's had 3 different surgeries over multiple years. He's on disability. He has all this burning pain down his legs. And if you have him stand on his right leg, good, okay. Stand on his left leg. Whoa, that's not good. So he can't even really walk straight. He's using his cerebrum to walk. Each time he moves his left leg and starts to put it on the ground, he's a little off, and then he does okay on the right, so he has to think really hard. So that's what therapists do a lot, right? Physical therapists are saying, you need to use your cerebrum to control your movement. Think harder about contracting this muscle. Think harder about it. What we're doing is we're saying, if this muscle is misfiring, it's because you've lost tensional integrity somewhere in your system. And we need to figure out where that loss of tensional integrity is, restore that tensional integrity, and then you walk below your cerebrum. You control your movement without having to think about it. You don't have to. We shouldn't have to think about moving, right? We just do it. We think about our goal. We want to go over there. We shouldn't have to think, oh man, I want to move this leg like this and this. There's something wrong with the tensional system. So this idea of Biotensegrity being applied in robotics, let's see if...
Discovery Channel filming. We made a successful launch at 1:52 p.m. of the large hex runner, and it went to world record speed for a robot, demonstrating stability and the concept that stability at these speeds is geometric, not a matter of traditional control methods.
So with the Fast Runner project, we're trying to show that it is indeed possible to do really fast, efficient, graceful running using very little feedback. With most running and walking robots, we have a lot of sensors, and about 1,000 times a second we read what the sensors are doing, do a lot of computation to figure out what the actuators should be doing, and then send a desired current or torque or command to the actuators. And we have to do that really quickly or the robot will fall down. As opposed to that, with the hex runner and the fast runners, everything is done mechanically using springs and linkages. All the feedback mechanisms happen physically. So instead of having to do a lot of computation and have a lot of sensing, as you squeeze the throttle on your RC remote, it speeds up the motor, gives more power to the motor, and just based on the dynamics and the geometry of the mechanism, the robot's stable.
Ooh, based on the dynamics and the geometry of the mechanism, the robot is stable, and it moves, right? So the structure is the function, right? So you don't have to have lots of neurologic control or electrical control through sensors, and if you saw the traditional robot, he's like, and that's the way we think of human movement, is we got to pull on this bone and move it this direction. But when the geometry of the connective tissue is taken into consideration, then you get a whole different understanding of how we move. So not all feedback is neurologic. So based on these ideas, I did some injections in this guy in certain areas. And again, look at that lecture from last year, or come to one of my office workshops if you want to see this case in detail. But after, this is just lidocaine dextrose injected in some certain fascial locations, and then he can stand on his left leg, right? So Steve Levin inspired me to start learning this stuff. Steve Levin is an orthopedic surgeon who quit orthopedic surgery about halfway through his career because he realized he was destroying the Tensegrity system when he went in and made these cuts. And he switched to basically manual manipulation and injection to treat pain. And he's a systems thinker, systems scientist. He's an aficionado of Ken Snelson. This is a Ken Snelson sculpture that he bought. Here's a little thing on his porch that he likes to show how oscillations happen. So I wrote about this kind of stuff in a new textbook that'll come out in September, and Ingrid Kolstad is here, and I think presenting later today. Is that right? I was honored to be asked to do this, but I think the world of medicine is open to a whole new understanding of anatomy and biomechanics. And it's starting to move in that direction. So if we understand tensegrity at its base, this is what I propose in that chapter is, and we'll go through each of these one by one. Tensegrity structures are closed, stable systems of two forces, tension and compression. They maintain structural integrity via continuous tension, discontinuous compression. They store energy as pre-stress in the tension elements. They create maximum stability with minimal mass. They instantaneously diffuse outside forces through the entire structure. So you get communication body-wide instantaneously. You don't have to transfer sodium, potassium across membranes and get this action potential going down a nerve, which takes time. It's instantaneous because it's built into the structure. And these structures naturally produce oscillations without dissipating stored energy. So you get oscillations in biologic systems all the time, right? Like your heartbeat and your breathing and your walking. Let's see. Okay, so they're closed, stable systems of two forces, tension and compression. This idea developed out of a sculpture done by Kenneth Snelson in the 40s, and Kenneth Snelson called it floating compression. So this floating compression, this is an example of Kenneth Snelson's sculpture that's at the Hirshhorn Museum at the Smithsonian in Washington, D.C. And you can see how these compression elements are floating in a continuous network of tension, right? So really helps to visualize in a different way. The structural integrity is because of the continuity of tension. So the primacy then comes in the tension, not the compression. Right now, the primary medical specialist that involves musculoskeletal medicine focuses on the compression elements, right? The bones, the orthopedic surgeons. And that's because of x-rays, and that's the way we see our structure. What we need to become is the primary people who understand tension, the continuity of tension in the soft tissues. It's much more complicated and difficult, and you have to use your whole body and all your senses and your palpatory skills to really understand this. So that's what we would like to see happen in the medical world as we go forward. So this floating compression, this is Kenneth Snelson right here. And what he's doing, this is a non-tensegral structure at this point because there's not a continuity of tension. It's kind of leaning over and flopping over. And what he's doing is slowly putting tension in all these right areas, is balancing the tension, and then it'll be a stable structure, a stable sculpture. So what he's done, though, while putting all this tension, is he's stored energy into that system, right? So as he's pulling on this, he's transferring the energy that he's gotten from the food he's eaten through the muscles that he's using and the tensegral system in his body, and storing that tension in this wire. And here we are, this is 1977, so what is that, 40-something years later? And that tension, that energy he put into that system is still there. The sculpture's still standing, and the energy that he put in is still in that structure. So this type of system creates maximum stability with minimal mass, and the person who had the insight of that was Buckminster Fuller. Fullerines, and I don't know if you've heard of, he was really eccentric, and he had the commonality, I think, with David Hirschfield that Heidi just said, is he's never been inside the box. Right? I thought that was a great quote. Heidi just said that as we were listening back there listening. So Buckminster Fuller was like that. If you try to read some of his books, boy, it's a task. They are very esoteric. But he came up with the original geodesic dome. He influenced architecture. When he was teaching Kenneth Snelson as a college student at Black Mountain College, when Kenneth Snelson brought in his first floating compression deal, and the first thing that came to Bucky's mind was tensegrity, tensional integrity. The integrity is the tension. The tension's the, right? That's the stability. So that informed his design of a geodesic dome. And what he found and what he started realizing is that this instantaneous diffusion of outside forces through the entire structure is what creates the stability. So I wasn't able to do that. If you take Bucky and you stand him on top of this geodesic dome, the dome doesn't deform under his feet. The whole dome shrinks, right? So one of my favorite things to say is if I squeeze my right earlobe, my left great toe just changed shape. Right? Just instantaneously as I did this. Now I can't feel it. Nobody could probably sense it. Now I've had several osteopaths here. When I was running the meeting in 2011, they gave me a group treatment after I was like stressed and wasted by the end of the day. I'm laying on the table. One's holding my head, neck, one's holding one leg, one's holding the other. Paul was one of those. And one of you guys said, "Oh, did you feel that?" And somebody at my foot said, "Oh yeah, I felt that." And I was like, I didn't feel that. What did y'all feel? They felt something tensegrally, right? They felt something. And the more us MDs palpate patients, the more you understand what DOs talk about. It's like, you can feel this, right? You can feel something. Now, do I have to explain it with data to prove it's true? No, there's some truth in your hands, right? If you just repetitively palpate patients. So, tensegrity structures also then naturally produce oscillations without dissipating stored energy. So, screw the pathology, focus on the dynamics. That's what Steve told me one day in a conversation we were having on Skype. And these oscillations, now what I've done is put a little bit of energy through the muscle with my finger there, right? But the energy continues to go. It continues to oscillate, oscillate, and oscillate. So when we think about movement with muscles, are the prime energy of our movement as we walk, as we do oscillating movements like walking, the energy comes from the connective tissue, not the muscles. And it doesn't dissipate. That's why it's so easy to walk, unless you've had an injury and you've lost some of that tensional continuity. Then you have to contract a muscle harder to do the movement, and you're using more energy, right? So bones should float. So one of the things that's fun to do in exams, and we did yesterday in one of the workshops, is if you find the loss of tensegrity and you introduce a little tension with your hand, not like pushing hard, but if you find the right spot, then suddenly that bone that they're trying to lift becomes your leg just floats up, right? Or if they're laying on the table and you tell them to lift their arm out to the side, laying prone, and they're like, and then you find the right spot, you hold a little pressure maybe at the origin of the serratus anterior, then they go, whoop, and the whole thing just floats up. So you can see it visually. And if you see it, you understand it suddenly. You go, they're not pulling on that bone anymore. Now it's just floating up, right? So that's what I spend all my days doing in my office, is trying to figure out these little systems and where every little collagen fiber and what it's doing and why it's oriented in this direction in this muscle. It's a little obsessive, I admit, but it's fascinating to me, right? Sorry. I stole that from, Robert Schleip, I think. But so Robert Schleip and Carla Stecco are down here. Carla is an orthopedic surgeon in Italy, and she basically spends all her time understanding fascial anatomy. Robert Schleip is the director of the only fascia research lab, I think, in the world that's totally dedicated to fascia research at the University of Ulm. And he helped organize the first Fascia Research Congress, 2006 or 7. And so they put out this statement last year, I think, 2016, because everybody throws this word fascia around. What is fascia, right? So they said, what we need, this is kind of that oscillating between distinctions of humans and wholeness of God, right? Fascia indicates a sheath, a sheet, or any number of other dissectable aggregations of connective tissue that forms beneath the skin to attach and close, separate muscles and other internal organs. So it's an anatomical definition. It's separating things out to try to understand them. When we talk about the fascial system, we're talking more about the functional aspect of the larger fascial net, the connections. So a network of interacting, interrelated, interdependent tissues forming a complex whole, all collaborating to perform a movement. So you can only understand so much by separating things down into parts, right? So this is an attempt of that oscillation of viewpoint. So Frank Willard, who has presented at this meeting many times, let me use this slide because the mesenchymal fascia is laid down in the embryo before the other tissues of the mesenchyme. So the fascia becomes the context for every other tissue. Every muscle you have is simply a fascial network with muscle cells in it. Every bone you have, bone is a connective tissue, remember we learned in med school, every bone you have is a connective tissue network with lots of calcium and other things in it, right? So it's interesting to think along those lines. So whenever we learn anatomy by dissecting out, we've suddenly lost the context. The context is gone. It's like we're reading a novel by reading little bits and pieces here and there, right? Instead of understanding the whole story. So this limb bud that develops out to the side is an embryo, is a fascia first, and then muscle cells start developing with it. And then those muscle cells and fascia start to migrate, and they migrate to the midline. I guess, I think we'll get to that in a second. I have a different picture of that. No. Can't remember where I put it in this particular lecture, but those migrate, some migrate to the front of the chest, like your pec major. So your pec major is your arm, and it's right here. This is your arm, right? And your trapezius and your latissimus dorsi. So your low back is your arm, contains part of your arm. And so when workers' comp tells you that, they injured their back, their arm can't hurt, you can't treat that part. Like, well, but the arm pain started, and you stress their latissimus and they get their arm pain and their latissimus is in their low back, and then you go, I'm getting out of the workers' comp system because I have to see things holistically. Right? So I did that years ago. So to sum up and make it really simple, which I love simplicity. I don't like simplistic thoughts, but I like simplicity, right? Biotensegrity-based anatomy and mechanics can be summed up in two simple phrases. One, bones float, and fascia communicates. So just keep going back to those two. Bones float, fascia communicates. So biotensegrity-based anatomy and biomechanics, the most rapid communication in your body occurs via the pre-stressed collagen fibers of the myofascial system. Pre-stressed, the energy is already in the system, right? So if you're looking at muscle contraction only, you're not understanding movement because the tension's already in the system. If you go in and watch an pediatric orthopedic surgeon do a hamstring release, they're under anesthesia, they're completely relaxed, there's nothing happening. Take the blade, you get the fibers of the muscle going like this, just take the blade like this and put it on the muscle. All these muscle fibers just start pulling away from each other, right? Because they're all under tension. without any energy going into the system, they're completely right. They're not contracting their muscle, right? So muscles are not structures that pull on bones to cause movement. Keep telling yourself that. Bones float in a variable tension network consisting of muscle and fascial elements. Fascial continuity provides the passive tension and stored energy in the form of pre-stress. Muscle fibers provide the dynamic tension and the fine-tuning of movement, not the primary energy of movement, but the fine-tuning of movement. And bones move or remain stable if there's outside force because the tension around those bones change. So they just float. The bones go along for the ride. Every collagen fiber is important. So if we apply these concepts in the clinic, the primary thing we keep in mind is tensional continuity when we're looking at a patient. And so then the history becomes a search for the loss of pre-stress. I'm always asking, have you had any injuries? No. Ever had a slip and fall? No. Ever sprain your ankle? No. Well, I've rolled my ankle. Oh, really? When did you do that? Oh, I do it all the time. Oh, when did that start? Oh, I played basketball when I was in college. Oh, really? So you start realizing there's these stresses that people have gone through, either a specific trauma or repetitive trauma from a sport, from a profession, from whatever it is. So this loss of pre-stress then becomes a source of muscle hyperactivity or recruitment. Recruitment's poor, the muscles become hyperactive. And this includes people with spasticity, for instance, which is near and dear to my heart. I ran the spasticity clinic at the Children's Hospital for 12 years. And their spasticity is because of a central nervous system, upper motor neuron injury, right? That's why they have spasticity. But their spasticity gets worse, a lot of them, as they grow. And their glutes get weaker, and their hamstrings and their quads get more spastic. And it's not just because of their neurologic injury. If they lose tension in their fascial system that controls their lower extremity, which we're going to talk about here in a second, then they get more and more crouched. They roll in more and more. If y'all can see, right? Here we go, over here. They get more and more like this. They get more and more spastic here. More and more. This gets weaker and weaker. Why is this getting weaker and weaker? I think it's because this fascial structure is under an abnormal stress. It's beginning to give way more and more. Then they're trying to compensate with their overactive upper motor neuron muscles, right? So you can treat spasticity by doing prolotherapy to their gluteal complex, which I've done in multiple adults with CP now, and or spasticity from like hemiplegia, stroke. If anybody knows of some connections of an organization that would be interested in researching these ideas with ultrasound, looking at hip extension, muscles, and all, talk to me afterwards. That's one of my things that I need to get back to. I left the spasticity clinic 5 years ago. Really want to get back to helping that population. But anyway, when you see muscle hyperactivity and myofascial therapists are saying, this needs to be stretched, it's too tight. That's what the problem is, it's too tight. Now, a lot of times why it's too tight is because there's a loss of tension underneath that tightness in the muscle, right? So use dynamics to find the loss of tensional continuity. Use muscle recruitment and global movements to find this. Use ultrasound and the dynamic potential of ultrasound to find a loss of tension. And then treat where there's a loss of tension with a regenerative treatment if other things have failed, or if you want to get them better quicker. So here's a simple thing to do, and there's a lot of nuances to doing a prone straight leg raise strength. So here's someone who has a problem on their left side, and let's try that again. So on the right, see, she doesn't really recruit completely at the beginning, but she can get full strength. This one, she really doesn't get full strength. But what muscle am I testing? Glute max? Max? No, that was a trick question. I'm not testing a muscle, right? I'm testing a whole myofascial continuity. And anywhere in that continuity could be the problem that's causing this loss of control, right? So here's another trick question. Which muscle am I testing when I'm doing prone hip external rotation? So you position someone like this, and you pull laterally on their foot. You're trying to internally rotate their hip, right? If they resist that, they're recruiting their hip external rotators, right? But of course, What are the hip external rotators? These little bitty deep hip, I mean, that's the main, what is it that externally rotates your hip? Yeah, I think it's the wrong question. So here's, blah. Well, her body rotates, her lumbar spine rotates. If you look right here, wish I had this pulled up a little bit like down here, but it's like her glute max isn't firing. The organization of glute max fibers is from the midline, sweeping lateral and distal, right? So that's part of what controls that hip internal rotation through an external rotation force. So if you look down here, there's a bunch of shots, and I'm not going to go through exactly what structures I injected, but I went there because if I held a little diffuse pressure in that area right there, her whole body was stable, and she just instantly locked that whole system. So, and then what I saw in ultrasound led me to that. So she's like ready to go. I'm like, okay, relax, relax. Okay, when I start to pull, don't let this move. Boom. Her lumbar spine's no longer unstable. Her hip is not is stable now. And one of the things she said, she has bad hip OA actually. But she said up here, her hip hurt when I did this. She felt groin pain when I did this. Down here, once I'd injected along here, she's like, oh, my hip didn't hurt when you did that. So where did the hip pain come from? Where'd it go? I didn't do anything to her hip. Is the pain generator in her hip joint? Where is the pain generator? Right? Pain happens with movement, mostly, and yet we think very non-movement, right? So Graham says in this book, the value of the Tensegrity model is that it provides a better means to visualize the mechanics of the body in light of new understandings about functional anatomy. Functional anatomy. We don't need to go into that. Here's a functional anatomy example. Tom Myers. How many of y'all learned from Tom Myers? Just a few. Oh, he's a great resource. It'd be great to have him at this meeting sometime. He's a massage therapist, but he's very academic, and he's done lots of dissection. And he has dissection workshops where he gets massage therapists to come and he shows them how fascial layers happen. And he talks about these global movements, like this one here is part of a spiral line that goes from your quads to your glute max to the contralateral latissimus dorsi. And so when you're controlling this kind of movement, you need to understand that, be able to visualize in your head that line of movement, right? So another interesting thing about fascia, the posterior layer of the thoracolumbar fascia integrates your upper and lower extremities with your trunk. And we went over a lot of this in detail yesterday in the little workshop we had. But lower trapezius, latissimus dorsi, and glute max all feed into the posterior layer of the thoracolumbar fascia. And there's the cross link. What's the cross syndrome? People in sports medicine. Dead butt, upper and lower cross. I don't use that terminology. I just like to learn the anatomy and understand the anatomy, and then whatever terminology you want to label it with, whatever. But the glute max fibers are in alignment on the right side with the left latissimus. So when you think about how we walk, right, your arm goes forward on one side, your leg goes forward on the other side, and you get this cross stretch in that lumbar fascia, and that helps propel you forward, right? It's just a natural way of walking. And then you don't dissipate the energy, but it helps propel you. So this is a glute max muscle. So when you look in the butt and you go, that's glute max, remember, there could be something going on in the low back that's causing that glute max to not fire normally. So here's the original patient that I showed you who couldn't stand on his left leg, right? This is his iliocostalis muscle as it's inserting onto the 12th rib, or not inserting onto the 12th rib. Overlying it is serratus posterior inferior and latissimus dorsi fibers, which are upper extremity muscles at your 12th rib, right? They partially attach there too. And this is his right side. So part of the reason he couldn't hold himself up is because his iliocostalis was not attaching well to his ribs. So if we push on his right side, here's his iliocostalis, there's the outer layer of the fascia going all the way down. I'm pushing on it, trying to get it to kind of slide off of that, and it's holding. On this side, it's just not really attached. There's just this gap floppy mess, right? And he had the same thing, not just at the 12th rib, but at the 11th rib. Now this is to a lesser extent. It doesn't slide off as much. There's not as much hypoechoic region in here, but it's not stable. It's sliding around more. If you go up to the 10th, and you don't treat an image, right? You treat a patient. So you don't treat this just because it's floppy, but he's tender there. He's not tender at the right side. If I hold support there, his prone straight leg raise is much better, right? If I do kinesio tape there and have him walk around, he's like, man, my back doesn't hurt as much. I can stand better on my leg. It's because I'm introducing some tension into that system where there's a loss of tension, all the way up to the 9th rib. Then you get to the 8th and it stops doing this and he's not tender. So we did a couple of treatments on him. Actually, we've done 3 now. So this was the first, and then 3 months after the first, he's able to then, he has a little loss, and then he's able to hold it. And then as he starts to unload, then he loses it again. So in this treatment, we treated more of his SI, and then we treated his glute med. There's a reason for that, but, and then he came back 3 months later, and boom, he's solid. Now, he didn't have any rehab. I didn't send him to physical therapy. I confess as a PM&R doctor that I did not send it. He had been through like years and years and years of physical therapy. Years. He didn't want to go to physical therapy. And so, but when his tensional system improved, the pre-stress, then his muscles started to fire more normally. Now, that doesn't happen for everybody. I think most people need physical therapy to recover this well, but he recovered particularly well. He was on chronic hydromorphone, and he just started tapering that on his own, just completely got off of it. So, let's see. It won't advance. Was that the last? That was the last. Okay. I have until when? 10:30. Anybody need to get up and stretch, move around a little? No? Because we're going to go through some detailed anatomy of the quadriceps now. Isn't that exciting? This, neuromusculoskeletal pain lessons from the myofascia. So if you take all these principles we just talked about, and then you go to a specific area, you can start to apply them and start using your human brain to dissect down and understand individual components of this holistic Tensegrity system. So let's apply that. Again, I still have no relevant financial disclosures. So from this talk, I hope you come away with, what is the pain generator is a really poor question, right? The pain generator is not one thing. The pain has to do with function, with overall movement. So we need to ask bigger questions, understand muscles as a continuity, and apply Biotensegrity and detailed myofascial anatomy to the problem of knee pain. So the eye sees only what the mind's prepared to comprehend. So we have to have an understanding in our head before we look at a patient in order to see something, right? That's what medical education is all about. This is Graham's reminder of Graham's statement about how visualizing through Tensegrity helps us understand patients. So this guy came in just a couple months ago, and he's 41. He's real wiry, strong guy. He works in construction, putting in high-end kitchen stuff, and has his own business doing that. He had 5 years ago, he injured his knee. Well, let me restate that. 5 years ago, he had knee surgery because of an injury. And the injury was kicking a bag, you know, like doing a martial arts move. And he felt something pop in his knee. And he went in and he had surgery on his meniscus. That surgery helped. He did pretty well. He had vague symptoms that were manageable. And then he helped his sister put in stuff in his kitchen. He was on his knees all day doing the work that he has other guys do a lot of the time. And now the knee pain's been back, and it's just been going on and on and on and on. So we can kind of understand maybe it's not in the knee, even though he had a meniscal tear, right? There's a lot of asymptomatic degenerative meniscal tears, for instance, right? MRIs show, you know, like 30% of 50-year-olds that don't have knee pain have meniscal tears. So going in and operating on degenerative meniscal tears hasn't been proven to be very effective. So maybe the pain source is somewhere else, and the degeneration is caused by something somewhere else. So here's trigger points in knee referral. So you can say, okay, vastus medialis, he has some pain along here. Maybe it's a vastus medialis trigger point. So let's test something. So I'm about to push down on his leg. What muscle am I testing? Quadriceps. No, it's a trick question. I'm not testing a muscle. I'm testing a whole myofascial continuity, right? Okay. See, it's biased in our heads to think individual muscle, individual joint, this is what I'm testing. It's like, no, you're never doing that. It's impossible to test one muscle. Impossible. Can't do it. So just throw that out. Quadriceps is 4 muscles. Well, then you're testing hip flexors, and then you're testing his abdominal core strength, and you're also testing, you're testing a whole myofascial continuity. So visually, you can look at the movement and get a quality of where is this breaking down? Where is this whole continuity breaking down? So as I start to push, so what was confounding about him is he really, once he got to me, he didn't have much knee pain, but he's like, I know there's a big problem with my knee, and I don't want it coming back. It's a mild problem again, but I can tell there's something wrong. But he's not tender anywhere. A little bit tender along the medial joint line. Okay, well, he had part of his meniscus taken out, no degenerative arthritis, and this move he doesn't have any pain with. He can do a single leg stand, single leg squat, way down, back up. Far better than I can, far better than, and he's like, no, my knee doesn't hurt when I do that. Okay, well, where's the problem? And then I do this, and he's like, he gets this like horrible look on his face, like, oh my gosh, why can't I hold that up? It's like, does it hurt? No, it doesn't hurt, I just can't hold that up. Okay, all right. So I did some injections, I'm not gonna tell you exactly where, with lidocaine dextrose. And if I can time this right, I'll get to where we injected and what. So then he's good after the shots. So let's talk about quadriceps anatomy. This is vastus medialis. We think of it originating from the femur, inserting on the patella. We memorize all of our muscles by origin and insertion on bone. And that's not what they do, right? So if we look at vastus intermedius, originating from the femur, inserting on the patella. If we look at vastus lateralis, originating from the femur, inserting on the patella. And then rectus femoris, the one that crosses the hip, originates from above the hip, inserts on the patella. So they all basically pull the patella this direction, in our understanding. So if you lay someone prone on the table, and you put a probe, here's quadriceps muscle, the farthest posterior component of the vastus lateralis. If I put a needle in this direction, we'll get a twitch. Oh, there was a twitch. So what did that muscle pull on? Did it pull on a bone? No. It pulled on this right here. Anybody know what that is? It's a fascial plane. It's the lateral intermuscular septum, okay? Which is a very important structure to me in my mind and has been for years now because of seeing things like this. So here's a picture from Carla Stecco's textbook, Atlas of the Human Fascial System. What she does is dissection on fresh cadavers only, because she needs to see fascial movement when she pulls on something and see what the fascial response is. So here's the lateral intermuscular septum on the posterior thigh. On this side is hamstring, short head of the biceps femoris. On this side is vastus lateralis. And look at these fibers and how they're organized, right? Look at the angle. And those are originating from that lateral intermuscular septum. They're not originating from a bone. So how do we understand that muscle now? We've been taught they originate from bones and they insert on bones. No, they don't. So what's the purpose of that muscle? What does it do? So Watanabe in 2009 argued that actually the vastus intermedius comes all the way back to the lateral intermuscular septum. I don't know if you can see these cross sections, but he's labeled this VI, lateral IM septum. These are hamstrings. And he's saying it's vastus intermedius, actually. It's not vastus lateralis. It's going all the way to that lateral intermuscular septum and pulling on that in the lower part of the thigh. Higher up, like mid-thigh, it's the vastus intermedius doesn't reach that. So how do we understand that? This is a study we published. Antonio Stecco, who's Carla's brother and who's a PM&R doctor, has done a lot of these dissections as well. So I met him at the Fascia Congress, and I was trying to understand glute max. Sean Mulvaney and I were talking on the way after our board meeting last night. And he's like, glute max, what's up with glute max? How do you understand it? It doesn't insert anything. There's no bone it inserts. It doesn't insert into any bone, really. Sort of. But we talk about a tendon that inserts on the femur. There's no tendon. You look with ultrasound, there's no tendon. And yet they show it in a textbook, right? What it is these muscle fibers are embedded in this continuity of fascia, which is the lateral intermuscular septum. This is the inferior part of the glute max. About 20% of the fibers pull on the lateral intermuscular septum. So they tension that septum that is being pulled on also by the vastus lateralis. That's interesting, right? So if you think about glute max and the way they sweep from midline to medial to lateral, proximal to distal, glute max. So it's pulling on that septum, and then the vastus lateralis is also pulling on that septum. So this is the vastus lateralis fascia. This is a left leg. Greater trochanter is here, glute med. And so this max is pulling on that, and then these fibers are pulling on that. So there's this tug of war going on between these two muscles. Yep.
Where does our iliotibial band come in?
Excellent question. Iliotibial band. The iliotibial band is basically, if you want to think of it this way, the tendon of the glute max. Right? 80% of the glute max pulls on the iliotibial band. 80% of those fibers. So if you had to assign a bony insertion, you'd say it's where the iliotibial band inserts. That's the glute max insertion. But please don't think that way. It's a fascial continuity. So the glute max is a fascial tensioning muscle. All muscles are, of course, but it's a great illustrator because there's so little bony attachment of that muscle. So let's look at the iliotibial band. Becker looked at this in 2010, and all these references are in the last slide, which you'll be able to access these slides later. But this iliotibial band, this is a nice clean view, and of course any anatomy that looks like this is out of context, right? You've lost context because you've removed so much connective tissue. Here's short head of the biceps, here's vastus lateralis. If we take that off, now this is confusing because we've switched extremities. We're on the contralateral side now, so this is proximal, this is distal. And here's your vastus lateralis. Becker argues that there's really three separate muscles that sort of blend together that define the vastus lateralis. Here's the superior proximal part, and the central part, and then the deep distal part. And the orientation of the fibers is different, and the way they interact with these strong aponeuroses are different. So if you cut this aponeurosis of the vastus lateralis, which by the way blends with part of the glute med insertion up near the greater trochanter, and you peel that back, they mapped out all the nerves that go, this is rectus femoris, but under this proximal superficial aponeurosis is a deep distal aponeurosis of the vastus lateralis. What's confusing about this distal part of this muscle is it's supplied by the nerve that supplies the vastus intermedius. So do we call it a vastus intermedius or do we call it a vastus lateralis in this distal part? And so there's disagreement in the literature on what we call these distal fibers that are more lateral. And here's those fibers. And they were very confused in this article, and they commented that others have been very confused by this, that these fibers have an almost circumferential orientation. Like they're going circumferentially from posterior to anterior on the femur. So they're not like going distal very much to the patella. So how do we understand that? Well, I've wondered this for years too, because I see these things like this. This is a person laying on their back. He has knee pain, of course. And these deep fibers, this is vastus intermedius. Lateral is here, medial is here. So I'm going to introduce a needle down here, going towards this myoosseous origin of the vastus intermedius. So the intermedius has the largest origin from the femur. And as I go down and hit this muscle, watch what the twitch does. It's not pulling longitudinally, it's rotating, right? It's rotating. Now, if it's pulling on the patella, why is it doing that, right? Well, this is a great article from Yoshida, 2017. The most detailed description of the attachment, the bony and not bony attachments of the vastus intermedius. So it's a little confusing, but here's your femur. This is anterior. This is posterior. What they did is they peeled off the whole extensor mechanism and looked at the undersurface of that whole mechanism. So they peeled it off, cut all through here, rolled it out like here, and they looked at the deep surface. And so anywhere it attached to the periosteum, it has this white coating, right? Oop, sorry. So this is vastus intermedius. This is vastus lateralis oblique, or a continuation of the vastus intermedius, one of the two, whatever you want to call it. And then you go over to vastus medialis and look at it. There's like no bony attachment. There's just this little bony attachment right here of the vastus medialis. Okay. So by far the largest orientation of the vastus, or largest origin from the femur of the quadriceps is the vastus intermedius. And the vastus intermedius tend to have a rotational pull to them. And those muscles pull on the lateral intermuscular septum, which is also pulled on by your glute max. Right? So you're starting to see a rotation, right? Of midline posterior to lateral IM septum, glute max to lateral IM septum, vastus lateralis and intermedius, continuing to rotate and go towards the patella, see? And then, let me come back to that if we have time. And then you get down to where does the vastus intermedius tendon insert on the patella? If you follow it, it actually inserts more medially, and it has the biggest pull on the medial patellofemoral ligament. That's a little confusing, right? So when they talk about the vastus medialis, or you dislocate your patella, you go in for surgery. The standard surgical technique is attach the vastus medialis to the medial patellofemoral ligament. But they did this study to show that, hey, that's the wrong attachment. You're attaching the wrong muscle to the medial patellofemoral ligament. Like ligaments are supposed to support more than the bone, but they're tensioned, like David Harshfield just said. They're in series, not in parallel. Muscles pull on ligaments all the time. They pull on joint capsules all the time. So if you follow this, this is looking from inside the joint, the undersurface of the patella here. And you've got vastus intermedius tendon coming all the way over to the medial side of the patella and tensioning this medial patellofemoral ligament. So again, think of the rotational control of someone who's having patellofemoral pain or valgus knee deformity, lateral patella, like your older women with degenerative arthritis, and they do this all the time. Right? So where's the line of continuity? Glute max all the way to here. That's the fascial pull. It helps you control your internal rotation as you bend. Right? So when you have someone who stands up and they go, I feel knee pain. Where is it coming from? Is it coming from the knee? It could be coming from the myoosseous origin of the vastus intermedius, because that's not turning on at the right time to help control that rotation. Right? Yep.
Would this also be one of the responsible mechanism for dislocation of patella laterally?
Right. Yeah. I mean, how many arthritic knees do you see the patella riding lateral? It's the most common thing, right? Why did that develop over all the years of that person's life?
And how many lateral release surgeries?
Lateral release surgery. Does lateral release surgery make any sense? By the way, that's how I got into my whole profession, as I saw one of the world's experts on that surgery when I was in internship. And he operated on me, and I give him credit in 1992 for not doing the lateral release. Because he said, hey, your patella was tracking fine when I woke up. He said, oh, under anesthesia, your patella was tracking fine. It wasn't being pulled too far laterally. So your cartilage was worn down almost to the bone. You had grade 3 or 4 chondromalacia on the superior part of your patella. So I cleaned that up, and you can get back to running in 6 weeks. Well, I was running before the surgery and having pain after running. After the surgery, I couldn't run at all, and I had pain with walking. So I followed up with him, and I said, I have pain all the time now. I limp everywhere I go. Oh, well, we need to cut your tibial tuberosity, lift your kneecap up, shift it over. You might not do sports again, but you can walk without pain. So get on my schedule, out the door. And I'm an MD at the time, right? But I was going into psychiatry. I was totally intimidated by this world expert who has his own textbook on the patellofemoral joint. So I didn't ask too many questions. One of the things I asked during rehab was, why is my right knee going bad? Well, it's overuse. I was training for a longer run. I discovered mountain biking. Well, but why isn't the other knee going bad? I mean, I'm using them the same. I do all symmetric activities. The right knee's going bad. It took me years of going to conferences like this, learning stuff over the years, changing specialties, all that, to figure out that I had damaged my pelvis in a mountain bike injury about 4 months before I started getting knee pain. And torqued my SI joint and damaged the adductor magnus attachment at the ischial tuberosity because I landed right on the bar of the bike. That pain resolved very quickly, but then over 4 months of running and mountain biking, I started getting knee pain. So again, the problem wasn't at my knee. It was higher up, which chiropractors and osteopaths have understood for decades, right? And MDs are just maybe barely getting into the idea that these things are connected, right? I'm an MD, so I can say that, right? I got a couple more minutes. I got 5 minutes. There's another major component that's like amazing insight into the quadriceps. Okay, you ready? This is exciting. Grob last year. Vastus medialis. The vastus medialis, the majority of the muscle, does not pull on the patella. It pulls on the vastus intermedius. Okay, so this is the diagram. The origin of the vastus medius, remember, all it had was this little bony origin, and then all along here, it wasn't attached to bone. The major origin is the medial intermuscular septum. So it's pulling on this fascial plane, and it's pulling on this vastus intermedius muscle. So again, think about rotational control of the femur, all right? And then alignment of the patella with the femur. If you have a poor attachment to the myoosseous origin, to the femur of this vastus intermedius, you've lost communication between the femur and the patella. Because remember, fascia communicates, right? So here's the direction of pull. The majority of these fibers are actually pulling on this vastus intermedius. The smallest part is pulling on the tendon and the patella. And this is the great MRI, and you can see this on ultrasound. So this is the aponeurosis of the vastus intermedius. And these fibers, they're not pulling this direction in that picture. They're pulling the direction of those red arrows. So they're pulling and tensioning this fascia, which is also being tensioned over here by these pulling this direction, which of course leads you back to what happens with your adductors and your hamstrings and how are they tensioning this fascial plane and this fascial plane to coordinate how your bone floats in space. It's really complicated, right? So here's one little example we'll try to show. So this is that vastus intermedius aponeurosis right here. This is rectus femoris. And I asked her to gently push her knee down into the pillow. She's laying on the table and she pushes down. And then you go to this side. Is it different? So I'm still trying to understand this, right? So then I asked her to push harder into the pillow. Do you see a difference there? Right? You see how this bone, it's moving around. As she contracts, it's like moving a lot more than this bone. And as she contracts harder, this gets more stable. And this sort of, it doesn't have a hard end point where it locks into place. It just sort of barely stops. Can y'all see that? Or do you have to do more ultrasound before you'll see it? Is anybody someone in here that does not do ultrasound that can see what I'm talking about? All right, that's good. I've had visual artists who look at the ultrasound, and I show them the ultrasound. They know nothing about anatomy, and they go, that side doesn't look right. I'm like, yeah, you're right. It doesn't look right. So K-taping, here's a simple thing if you want to try to apply this at home. Understanding this rotational, from IM septums, towards the midline, try taping people like this that have some patellofemoral problems. Try to help them pull together their vastus medialis and vastus intermedius and their vastus lateralis and intermedius and kind of cinch them together a little with a little kinesio tape. This guy, he wanted PRP. He jumped off. He was doing exercise. He's really highly fit. He jumped off and he landed. He's like, I felt a pop in my knee. He had no pain at all in his knee, nothing, everything's stable. There's just nothing at his knee. And this is what I said yesterday in the workshop. If you have a rubber band under tension and you let go of the rubber band, where do you feel the pop? Over here. But where was the problem? Over here. What he had was a tear at his vastus medialis, vastus intermedius junction. Subtle tear, but you could see it, especially when he contracted. So I put this tape on him like, okay, you're like Mr. Gung-Ho, you want to run this half marathon, schedule for some PRP. He scheduled. A few days later, he called him and said, I've been running with that tape on. I don't have any knee pain. I don't want to get the PRP. I'm like, okay, that's fine. So maybe he'll be able to rehab through this, right? He thought he wanted to be aggressive, but something more simple helped. If we had arranged the tape a little differently, would he have gotten as much symptomatic relief? I don't know. Got to play with it. So where do we inject this guy? Same place, VMVI injection at the midline. He injured it when he did that rounding kick like this, and it stressed that connection of the VMVI, and he felt something in his knee. Maybe he did injure his meniscus. I mean, apparently there was a tear that they operated on. And I found that because I applied a little pressure here before doing the injections. And again, you got to have them relax before you put the pressure on. Lift, push, solid. And he says, said, when I injected and tested, he just was like, how is that even possible? Like, did you put pixie dust in that thing? I'm like, no, doesn't matter what you inject, right? Well, you need a little numbing, otherwise you just irritate the muscle. We need 5 minutes for questions. So when you see someone with an arthritic valgus knee standing like this, realize that it's not just at their knee, right? And it may be that they had problems with their quads a long time that led to this deformity. Because with every step, they were off on their firing and they weren't coordinating where their bones were floating in space, and they were getting extra pressure and shear at cartilage, and that's what wore it down and developed this valgus deformity. So maybe their pain will be a lot better if you also treat these myofascial structures.